Well, thanks, Mallory and Josh, for inviting me to talk this evening. Although the title of the talk is Rationale of Steroid Use for Idiopathic Sudden Sensorineural Hearing Loss, we can add a few other ear diseases, such as noise-induced hearing loss, tinnitus, Meniere's, inner ear autoimmune disease. It's really the magic genie in the bottle, so to speak. Yeah, so the first document of sudden hearing loss in an otherwise normal person is in 1944. Klein's group really challenged us for the first time to think of sudden hearing loss as not just a peripheral, but possibly a central phenomenon. So all of us kind of know the classic definition of sudden sensorineural hearing loss, and its most stringent form is 30 dB in 3 consecutive frequencies happening in less than 3 days. But obviously that definition is very stringent, and most of us use a less stringent definition of 10 decibels in 3 consecutive frequencies, or 30 decibels in 1. It's kind of reported as 15,000 cases per year worldwide, but that's really underreported because some people who recover spontaneously never present to physicians. In the US, again, these numbers are underquoted. When we think about etiologies, we kind of think about the classic categories we go through for a lot of the disease processes: infectious, such as meningococcal, herpes, HIV, syphilis, rubella, autoimmune, trauma, vascular, as well as neoplastic as listed there. But for the vast majority, and greater than 90% or so, it's really unknown. So, a thorough history and exam is necessary to rule out treatable causes. MRI is almost always negative, as we all know. Fortunately for otologists, we have very few real ear emergencies, but sudden sensorineural hearing loss is one of them due to the time sensitivity of getting them started on steroids. Okay. Obviously, we treat them on prednisone, 1 milligrams per kilograms for 7 days. Some of us do tapers. I typically don't. I see them 1 week afterwards, and if there's no recovery, then I offer them intratympanic steroids. Prognosis, I kind of tell them it's a rule of thirds. A third of the people, they recover without any kind of treatment. A third get oral steroids or a combination of belt and suspender oral and intratympanic, and they tend to recover. And then in another third, they get the steroid treatment, but it doesn't recover. And there's really no way for us to know who's going to recover and who's not. Certainly some factors that have been linked to poorer prognosis is obviously delayed presentation. If the degree of hearing loss threshold shift is profound, if it's associated with vertigo or labyrinthitis, and certainly age seems to play a role, less than 15 or greater than 60 years of age. So the question is, why do we give them the option of steroids, right? So in 1980, this article was published in 1986, but earlier than that, Shitnick's lab found post-mortem temporal bone histopathology of patients with history of sudden sensorineural hearing loss. They showed inflammatory changes in the organ of Corti, very similar to someone that's had a viral cochleitis. And those findings are atrophy of structures or atrophy of the organ of Corti tectorial membrane, the cochlear nerves. And based on this kind of inflammatory picture, the steroid treatment was kind of conceived. So when we look at the inflammatory cascade, a steroid intervenes early on in the inflammatory pathway at the phospholipid breakdown level. And so Wilson's group in 1980, they are the first randomized publication on the efficacy of steroid treatment for sudden sensorineural hearing loss. And what they found was that if you treated these patients with steroid, they had a roughly five-fold benefit to hearing recovery. And that's really the first randomized study showing the efficacy of steroid for sudden sensorineural hearing loss. In addition, they, in the paper, they found that those with profound sensorineural hearing loss, steroid was really not helpful. Those within the moderate sensorineural hearing zone, steroid was found to be effective. And if they had mild sensorineural hearing loss, they found that the hearing recovered without even any therapy. So since then, there's been a lot of case series on steroid treatment for sudden sensorineural hearing loss, but the problem is the current literature is really diverse with variables such as the time of treatment, different kinds of steroids that's being used, hydrocortisone, methylprednisone, dexamethasone, different steroid concentrations, mode of delivery, such as oral versus intratympanic versus the use of a wick or a microcatheter. So we're really comparing apples to oranges in a way, and these are really case series. I would say the current algorithm, the clinical algorithm that most physicians follow, is based on this multi-institutional study back in 2011. And it was a prospective randomized study, including 250 patients. Half of them received prednisone at 60 milligrams for 5 days, followed by a taper. And the other half received methylprednisone. And what they found that if you had a loss of greater than 50 dB on pure tone average within 14 days of onset, and they got the steroid, their PTAs improved by roughly 30 dB when you compare the oral versus the intratympanic. So the conclusion was that there really wasn't any difference between getting steroid orally or intratympanic. So we kind of go back to the original question that I posed. Is sudden sensorineural hearing loss a peripheral phenomenon versus central? For instance, Klein at the time posed, is the acoustic nucleus region affected by the sudden sensorineural hearing loss? And the question of what are we really targeting with steroid treatment? So the peripheral organ of Corti is really just a very small piece of the entire auditory pathway. All of us, when we study for us in service and the boards, we kind of remember the auditory pathway with the mnemonic E. coli that referenced the major retrocochlear auditory centers, starting from the 8th nerve to the cochlear nucleus, to the olivary complex, lateral lemniscus, and ultimately the inferior colliculus. So the question is, are any of these retrocochlear centers involved or affected at both the onset of the hearing loss and over time? But the question again is, how do we study such idiopathic sudden sensorineural hearing loss? There's certainly no animal model for it. So, the rest of the talk kind of focuses on what my lab has been doing to address this specific question. And since there's really no animal model, we've kind of used noise-induced hearing model as an animal model to study kind of idiopathic sudden sensorineural hearing loss, since it's thought that noise-induced hearing loss is much like idiopathic sudden sensorineural hearing loss, inflammatory. And so it can potentially serve as a model to investigate the central effects of sudden hearing loss. Okay, so the association of noise trauma and hearing loss was studied for the first time during World War II, because that's when audiometers were first introduced. And what they found in soldiers, composite audio showed this characteristic notch that we now know, around 3 to 4 kilohertz with noise trauma. Okay. Realizing that acoustic trauma is linked to noise-induced high-frequency hearing loss led really to the first efforts for noise protection. Back in 1957. Back then, they didn't have OSHA regulations that we have today. So what that paper, the study showed, was that the parameters that are associated with noise-induced hearing loss include intensity, both intensity and duration of the noise exposure. Okay, and so this group studied 10 ears before and after 2.5 hours of a rock and roll concert that reached up to about 130 dB. And they also found this characteristic notch here that was similarly observed with the soldiers back in 1950s. So, how can we investigate the mystery behind sensorineural hearing loss? Well, via what I call reverse evolution, that is using an animal model, taking a clinical question back to bench research for answers. So the old dogma always has been that noise-induced hearing loss was thought to be damage to and subsequent loss of hair cells within the organ of Corti, specifically in the basal turn of the cochlea where the higher frequencies are. And the basal turn because it's the most, it's closer to obviously the outer, our environmental noise exposure. And that was in Lieberman's group published this loss of hair cells back in 1987. Well, in recent years, that old dogma has really been challenged, and there's been a real shift in that dogma where the presynaptic and postsynaptic complements, especially at 32 kilohertz in this mouse model, show that you have loss of what we call peripheral synaptopathy. The peripheral ribbons. Mallory, can you see the mouse on your screen?
We can.
Okay, so in a normal ear, you should have complements of these red and green, so it'll kind of look yellow. But in a mouse that's been exposed to loud noise, you lose that red and green complement. So you're losing that what we call peripheral ribbon synapses. And they were seeing, this group was observing that this is occurring way before you even have loss of hair cells. And they hypothesized that really that's why when some people come into your office and they say, I went to a loud concert, I have tinnitus and I can't hear, yet their audiogram is completely normal, right? And so the idea that, you can have what we call hidden hearing loss. On an audiogram, everything looks normal, but because they may be having these peripheral synaptopathy or loss of these peripheral ribbons, the audiogram that we have right now, it just isn't sensitive enough to pick up what's happening at this kind of cellular level. In addition to that acute kind of peripheral synaptopathy, when they followed these mice who had noise trauma, what they were observing is this is a control with the robust spiral ganglion cells. In the control as they're aging, so we're comparing that same mouse or not same mouse, but a different mouse that has aged. You can see at 88 weeks, there's some loss of spiral ganglion cells compared to your controls. But if you look at a mouse that was exposed to noise and it's aging, they're showing an accelerated presbycusis. You can see clearly there's a sparsity of spiral ganglion cells compared to their age control match. So what that's telling us is that not only does it cause acute damage, but they are more prone to early presbycusis. But again, the question comes back to, a lot of these patients, not only do they have hearing loss, but they have like debilitating tinnitus. They'll tell you that they have a hard time processing speech in noisy environment. So in a sense, a lot of the complaints that they have is really more central rather than peripheral. So we again come back to that research question that I posed to you guys early on, what's happening at the central auditory centers, right? So we used mouse models, and in order to kind of isolate what's happening in that E. coli, you can inject something called floral gold intratympanically, and it's a retrograde neuronal marker. So it gets absorbed by the nerve, and it traces along all the retrocochlear auditory centers, starting from the cochlear nucleus and so forth. And so we wait a while, and when we harvest the cochlear nucleus, you can see that the neurons get stained kind of in that yellow-green. Okay, so using this kind of animal model, this allowed us to next kind of investigate what happens at the central level. So just going through some of the ABR threshold, when a mouse is introduced to loud noise, and this threshold shift right here is the control, it's normal. In a noise-induced hearing loss model, you can see this solid gray, they have threshold shifts. If they get saline, which is a dashed gray here, there's no protection at all. Whereas if the mouse that got the noise-induced hearing loss and they received dexamethasone, there was some threshold shift recovery, okay? And then using that floral gold technique, what this slide is really showing is that when we count the neuronal cells in the cochlear nucleus and the superior olivary complex and compare the noise-induced hearing loss versus the noise-induced hearing loss plus saline mice, we see that there's loss of neuronal cells, but with dexamethasone steroid treatment, there's no loss of neurons. And when we compare the ABR thresholds to the neuronal cell count, there's a strong correlation within the cochlear nucleus and the superior olivary complex, meaning the higher the number of neuronal counts that you have, the better their ABR thresholds. So just kind of reviewing real quickly on what happens with neural inflammation. We kind of know what's happening in the periphery, but just as a review for some of you, in the central nervous system, well, first of all, in the periphery, we know that, you have initially after the insult, you have mast cells that are recruited within seconds after injury, followed by neutrophils within hours and macrophages within a day. But within the central nervous system, we really don't know what's happening. I'm sorry, I'm just going to review what's happening in the central nervous system. So the first thing that happens is if the cell body is damaged, that there's retrograde neuronal insult resulting in neuron loss. And there is no cell division in the adult brain to replace the lost neuron. So that mechanism has been pretty well established. What we don't know, especially within the auditory pathway, is who are the players. In the periphery, again, I mentioned that we know that there are macrophages, neutrophils, lymphocytes, but within the central nervous system, we really don't know who the major players are that's coordinating this cellular damage. I think this is just a review of the peripheral inflammatory response that I just mentioned. So it turns out that within the central nervous system, there are several key players, and the two of them, namely, are something called astrocytes and microglia. Okay, so what happens after an injury within the central nervous system is there's microglial activation. So they go from the string-like structures to this plump-like microglia. And astrocytes also go from these stringy-looking structures to a much plumpier-looking astrocyte. And then they go on to secrete pro-inflammatory elements. And then they, in turn, cause neuronal damage. And the interesting thing about these, the microglia and astrocyte is that not only do they regulate neuronal death, but by some of the cytokines and pro-inflammatory elements that they secrete, they also promote healing. So it's a little bit of how much, if there's an off balance of the pro-neuronal cell death elements versus pro-inflammatory and thereby healing elements, it can kind of result in more damage rather than doing good for our central nervous system. So here is a time-lapse video. Let's see if it'll happen in this format. Are you still able to see the slides?
Yes, and okay. I can see your mouse, so.
Okay, good.
Fingers crossed.
All right, so I'm gonna play the video. Let's hope it happens. Is the video playing?
Yes, it's playing.
Okay, so what you were seeing in the beginning was there was a little laser that was introduced, and within really seconds to minutes, all these microglia cells came to the center of the screen, doing its thing of trying to repair the damage. But again, if these are just microglia that are hanging out, as soon as there's a damage, they come to that area of the damage and start secreting pro-inflammatory elements to try to repair this. But again, if they linger on too long, they actually result in neuronal cell death instead of just repairing that area of the damage. All right. So our lab's theory is that we hypothesize that with noise trauma, there is not only damage occurring within the cochlea, but there's central ramifications in the cochlear nucleus and superior olivary complex. And certainly steroid treatments suppress activity of these cells with noise trauma. Now the next slide. Okay, so this is just kind of a cartoon version of what we think is happening. So if there is acoustic trauma within the cochlea, obviously it causes that peripheral synaptopathy, or the peripheral ribbons are damaged. But over time, that injury retrogrades and causes neuronal cell death within the first relay center of the auditory pathway, which is the cochlear nucleus, followed by the second retrocochlear auditory center, which is the superior olivary complex. So this is just a pictorial way of what we're hypothesizing. Now this is a busy slide, but you know, the takeaway message is that GFAP is a stain for microglia. DAPI is just a nucleus stain. And EBA1 is for astrocytes. And the top layer is noise-induced hearing loss with steroid. The bottom is saline. And again, the takeaway point is that, you know, with the steroid, it retains the same shape as the control, whereas if you don't treat them with steroid, they undergo these kind of morphologic changes. They're activated. Okay, so and the finding summary is really that acoustic trauma causes activation of both microglia and astrocytes, and that microglia cells within the eighth nerve, cochlear nucleus, and superior alveolar complex is similar to the controls in the first 3 days after noise exposure, but with DEX treatment or steroid treatment, there's a shorter period of inflammatory damage. Therefore, it's providing kind of a neural otoprotective role. So the goal, a future goal, is really to develop strategies to regulate their activity and to kind of hit for the steroid to reach the central auditory centers, not just peripherally, in order to protect our neurons. So the question is, what other variables other than microglia, what other factors could account for sudden sensorineural hearing loss, the unpredictable hearing recovery, and their response to steroids? So the another question that our group kind of wanted to ask was, does genetics play a role? And does genetics also play a role in kind of in deciding whether some people respond to steroids or not? Certainly, for centuries it's been known that hearing loss can be passed down in families, as you can see from our early 1600s quote that the deaf and dumb had to abstain from marriage because they saw that their offsprings also had the same disease or characteristics. But at that time, they didn't know what it was. And in 1814, there was this 4 generations within a single family with hearing loss. And it was recognized that this was the first time that otosclerosis could be hereditary. Certainly in Martha's Vineyard, 60% of the population with hearing loss was noted. And they were all descended from a single individual. They even developed their own form of sign language termed Martha's Vineyard Sign Language. So obviously in 1990, we began this huge human genome project. It was one of the few government-funded projects that finished on time and finished under budget. They had estimated $3 billion, but they finished the project costing them $2.7 billion. And some of the well-known genes that were identified from that project, Alports, all of us know, Javel-Lang, Pendrim, Sticklers, Treacher-Collin, Wardenbergs. And today, we know of about 100 genes for single deafness genes, and about 140 loci have been identified. So the question was, could there be a genetic connection between sudden sensorineural hearing loss? There are various inexpensive methods of DNA sequencing, and then you can compare to the control group to identify for potential alleles associated with sudden sensorineural hearing loss, and that's what we did. We took patients who presented to us with sudden sensorineural hearing loss. We did a whole genome sequencing, and then we compared their sequence to a bank of normative data where we know that they didn't have any hearing loss. And based on this, we took about 29 patients of patients who presented with sudden sensorineural hearing loss. Some of the demographics are presented here. Their mean age in their 50s. Female to male was about the same. Pure tone at presentation was about 64. And then we split it up into pattern of hearing loss, meaning lower frequency versus mid frequency versus high frequency versus all frequencies. And then those who responded to steroid, out of the 29, 9 patients responded to steroids. So again, this was a very small cohort, and we had just finished this before COVID hit, and it's been on hiatus for about 2.5 years, and hopefully we can start this up again. But I'd like to share kind of our preliminary data. Based on those 29 patients, we identified, let's see, 6 novel mutations, and they were all within the myosin family. And it kind of shows you what kind of mutation frame shift, stop gain, this sense. And when you compare these patient characteristics of those who responded to steroids versus who did not, there really wasn't much difference between the two groups, right? But I wanted to cover a little bit about myosins. You know, myosins are involved in a lot of cellular activities. It's involved in movement, obviously, and muscle contraction, and ion transports. And within the inner ear, the first key to the cause of Usher's actually came from David Corey and Jim Hudspeth at Rockefeller in 1984. And they identified an unusual myosin near the tips of the stereocilia. And based on the location and its property, they proposed that the stereocilia tip had a deflection gate, a deflection-gated ion channel, and this myosin somehow allowed the channels to close and reset in hair cells. So this is just, again, a little cartoon rendering of the hair cells. So this is the myosin, and depending on its contracture, the ion-gated channels would either open or close, accounting for the action potentials between the perilymph, the endolymph, and the different compartments. So in a completely unrelated series of experiments, Gibson and co-workers were studying the shaker mouse. And the shaker mouse is a mouse model of congenital hearing loss with vestibular dysfunction. But what caused this was unknown at the time, but through studies, they again kind of localized deafness to the myosin mutation. So what I'm trying to get at is this is not the first time myosin has been implicated to inner ear dysfunction. So it's not so far reaching that perhaps myosin may be somehow related to sudden sensorineural hearing loss. But again, N of 29 is not a huge cohort, and it's an ongoing study, but it's something interesting, let's say. So, and in addition to the 2 models that I just went over, the myosin has also been linked to Usher's. And let's see. Let's skip that part. So I think the future of gene therapy is going to be very, very interesting. Currently, there are several gene therapy that are in play. One looking at for gene therapy for connexin 26, another looking at Usher's, another otoferlin. And so there have been really significant steps made towards cochlear gene therapy studies. It's still early on, but you know, if we can show that sudden sensorineural hearing loss is also somehow genetically related, hopefully there can be some exciting gene therapy studies that can be designed in the future. But again, we're in the very, very early stages to even think about that. So I think gene therapy for hearing loss is coming, but it is in the early stages. And I just wanted to acknowledge some of the players in helping with the gene study. And Madeline is our former resident. She's doing a pediatric fellowship in Seattle. Actually, she's graduating this year and she'll be joining the faculty in Oregon. Rahul is one of our former students. He's now a first-year ENT intern at Vanderbilt, and Joseph and Dr. Goldstein's over at our Genomic Institute. And a lot of the basic science stuff that I shared with you guys come from, obviously, without the hard work of all these players in the lab, I would have no data to share with you. But again, I'm sorry, this was a real kind of a rush talk. And Zoom talks are never as good as in person, but hopefully you got something out of it. So Mallory, I'm going to stop sharing.
Great.
And maybe take some questions.
Yeah, thanks, Dr. Kim. That was fantastic. Thought-provoking, and clearly we have a lot to learn. I'll open it up for any questions. I've got a couple, but we'll hold on for now.
I think you may be the only one with questions, Mallory.
Dr. Kim, thank you for this talk. Habib Rizk here. I just had a question about how did you hone in on the myosin mutation on those patients? Did you go in knowing that this is what you wanted to look at, or did you go a wide genomic mapping and this is what came up?
Yep, it was a whole exon genomic sequencing. So we went in not really looking at a specific gene. So their entire exon was sequenced and compared to the normative data.
Okay. Thank you.
Okay, Dr. Kim, I think I've got my thought together, but given the complexity of the etiology of sudden sensorineural hearing loss, knowing that it might be both peripheral and central and linked to potentially genetic predisposition, do you see that there in the future becoming any role for additional testing, such as genetic testing, to determine whether patients might be better or worse candidates for minimally invasive things like intratympanic steroids or not?
Yeah, so, as we kind of, the latest thing is personalized medicine, right? So in order to do that, it's not just about the disease itself, but it's about the genetic coding. So yes, I do think that going forward, you're going to have a combination of, let's take a more established disease entity, for instance, sudden or profound sensorineural hearing loss. If you know that they have a gene that is linked to cognitive decline, you know that patients with an implant with the cognitive decline isn't going to do as well with someone who it has cognition completely intact. So I think going forward, I'm using cochlear implant as an example because much like sudden sensorineural hearing loss, where we can't really predict who's going to respond to steroid, who's going to recover on its own, same thing applies to patients who get a cochlear implant. There is just no way for us to predict who's going to be superstars and who's not. Some people that we expect to do really well end up not doing well at all, and vice versa. And some of it is probably, there may be some genetic linkage to that. So in a similar way, I think probably it's not just about the audiogram, but the genetic imprint. And if we can develop more sensitive imaging tools that tell us, is it the peripheral, or is there some inflammatory processes happening at the central level? I think right now our diagnostic tools are so limited that, like my title slide kind of showed, the steroid is really the magic genie in the bottle. We really don't know any better. So we're just throwing steroids, hoping that it'll do something, but we need better diagnostic tools, basically.
That makes sense. And given that sometimes we don't know who is going to respond and who is not, what are your thoughts on throwing the kitchen sink out, something like oral steroids in addition to intratympanic steroids right from the get-go, and going for a series of intratympanic steroids versus one or none at all?
Yeah. So, again, just going back to Schutnick's studies, we know temporal bones show inflammatory processes, so that's why we give them steroids. But we really don't know at what level the steroid is supposed to be therapeutic at. Is it at the organ of Corti? Is it at the central? And certainly if you inject intratympanic steroid, really doesn't reach the higher auditory centers, right? So if someone has something happening at the cochlear nucleus level, then obviously intratympanic isn't going to work, and probably oral steroid would be better. But again, there's only really one randomized prospective study, and that's the study that was done in 2011. At least in that study, there was no superiority of the oral versus the intratympanic. But again, 120, not a huge, subject comparison. But based on that, it didn't really show a difference between getting intratympanic alone versus oral alone. So I typically tell patients, if you want belt and suspenders, you can have oral and intratympanic. But right now, given the limited evidence that we have, it doesn't really seem to make much difference. But where it does maybe potentially make a difference is if you got the oral steroids and you didn't recover, if the time frame is still pretty early on and not 2 months, 3 months, since the onset of the hearing loss, then I tell them there's some evidence that intratympanic, salvage intratympanic, may bump up your chances a little bit. And there's really no downside of trying maybe 2 injections. Normally you do up to 4, but typically I do 2. And if they really don't really show much response, I don't go on to a 3rd or a 4th, because it's really during the third or the 4th injection that you risk having a permanent TM perforation where the injection at the injection site.
That makes sense.
I saw Ted earlier. I don't know whether he's still on, but I don't know what you guys do in South Carolina.
Hi. We do a lot of different things, I'm sure, like you guys do, and all over the place. So I try to do belt and suspenders with oral and injected steroids at the same time. I don't have a set number. Like most of us, it's hard to get patients in at a prescripted time for a follow-up injection if they want another one. And yeah, the data are so variable. We see folks around us as well who, so-and-so does 3, so-and-so does 5, so-and-so does 7. I mean, there's so much variability to how all of us actually treat this. And the presentation is so weird too. My ear popped and I can't hear out of it anymore, right? Well, that's got to be a rupture of your round window membrane. It just has to be. So as we know, it doesn't have to be, right? So it's really interesting. Or my ear popped and my hearing came back. So it's interesting that there are so many presentations of how this starts, how it recovers. Yep, I could start to feel it recover during the 3rd shot or right after the 3rd shot, or I swallowed after the 3rd shot and then my hearing kind of came back some. So we have a lot to learn about this. I'm glad we have folks like yourself spending a lot of time trying to figure out different pathologies here. Very cool. Great work.
Thanks.
Well, thanks again, Dr. Kim. I think we'll leave it at that. Really appreciate your time, and such an honor to have you.
Okay.
Right.
Thanks so much.
Thank you. Thank you.
Bye-bye.